The broadcast is now starting. All attendees are in listen-only mode.
Good morning again, everyone, and welcome to our Wednesday Safe and Calm webinar. This is Deanna Mitchell with Leading Age Michigan. And we're kind of watching as the epidemic continues to drag on, and it's seriously surging in some areas, both in Michigan and in some other states. We believe that we are at a critical juncture here where it's time to define a new normal for the immediate and perhaps not so immediate future. We need to look toward an environment where seniors can be both safe and experience some quality of life. So Dalton's going to talk a bit about that this morning as we continue to work together to advocate for a more flexible but safe care delivery system for our residents. So this morning's webinar will follow the same format as we often do. We will provide a brief overview of our advocacy efforts, followed by a situation update, and then we'll move to a discussion of new resources and any guidelines. We have noted in the past several weeks that the number of directives and the intensity and frequency of directives has declined, but unfortunately, the issues facing our seniors have not. So at this point, we will now turn the presentation over to Dalton Herbal, our Director for Advocacy, for a brief update.
Good morning, everyone. Thank you for attending today. As always, you can find the handouts in the webinar tool. In case you need to leave early or you get swept away, you'll have them before you leave. Today, in our advocacy section of this presentation, we'll be talking about a couple of local things as long-term care remains in the political zeitgeist of the state during campaign season. And we'll also be touching on a couple things on the national level that I think everyone should be aware of. More specifically, we'll be talking about the PPP deadline extension, the Building a New Normal advocacy campaign that we're putting together for kind of an engagement effort on the behalf of the association and members and the residents. And we'll be talking about some reports that the Ombudsman office released, and we'll be discussing what's currently going on with Public Act 123, or what was formerly called Senate Bill 690, and then we'll be talking about the Emergency Housing Assistance for Older Adults Act that was introduced on the national level in the Senate. So as I said, long-term care, and in this specific instance, nursing homes, remain in the political zeitgeist of the time. This campaign season, long-term care is going to be an issue. And because of this, the Ombudsman office has been taking a more active role. In the past, before campaign season started, and during all the questioning of the state's COVID pandemic procedures, the Ombudsman office also offered testimony before various committees and legislators. And they've received direct questions regarding their COVID-19 response. And even some media outlets questioned them, and they appeared on some radio stations. In response to this, last week, they sent out a letter to every state legislator detailing the findings from the recent LARA infection control surveys in their district. These letters were on a per facility basis. They included links to Nursing Home Compare and other public data reporting sites. And LARA was not aware that this was happening, but is now backlogged with calls from legislators or their staff members asking for more data on nursing homes in the state. This just goes to show that nursing homes are going to remain a hot button issue. Long-term care is going to remain a hot button issue during the campaign. Everyone's concerned because of the COVID response and how political that has become in the state. A brief update on Public Act 123, or Senate Bill 690. As you may know, it was signed last Wednesday. I included a link to the Public Act language right here if you're interested. The department is currently working on guidance. We just heard back from them yesterday that they're hoping to get it out by the end of the week. So we'll see. We know with state government, the timelines aren't necessarily solid all the time. A couple of things we're asking for out of the process and advocating for with the department as they put all of this together. We'd like them to consider the additional $2 an hour for direct care workers as a direct wage pass-through and not subject to the variable cost limit. And we'd also like them to establish appropriate criteria for the PPE applications and the actual grant itself. The bill leaves a lot open to interpretation that the department's going to have to make decisions on. They've said they're going back to the legislature, looking for more detail from them. What was their intent? But really the final call is going to fall on the department's shoulders. So we're advocating on your behalf to make sure that the full continuum of care can have access to this $25 million grant pool, and that the definitions put forth in the bill, the actual language put forth in the bill meets the definitions that the governor's executive orders meet, because that would cover all of long-term care, specifically residential care facilities. This is just thrown in there, not defined, and that could mean a lot of different things to a lot of different people. So we are working on that with the department. This all leads us to opportunities for engagement. We'll be coming out with a comprehensive advocacy campaign or platform in the coming weeks here, really focusing on a couple of things. Engaging legislators is key during this time. And the governor's task force starting the long-term care task force is a good opportunity for us to get involved on that level, get involved with legislators, and just make our voices heard. We'll be kind of focusing on three main issues, those being the issues that were created by COVID and the need for consumer well-being, residential family visits and environments, preparing for the second wave, include a wide variety of stakeholders in these discussions, and increasing access to data for everyone so we can better understand this second wave and react to the second wave, not create policies that actually hinder quality care. And lastly, as Deanna touched on in the first part, we're going to envision the new normal for what is long-term care going forward. With this, we're looking for member input, and we're looking to define practical safety models for all of long-term care going forward. Moving on to some of the issues on the national level that we've seen. A housing bill was introduced on July 2nd. It's about $1.2 billion and is a companion bill to a bill in the House. A companion bill is just a copy of a bill from another chamber that was introduced in the other chamber. You often see this when people want to try to get something done so they can move quickly on it, or if the group sponsoring the bill is not having luck in their chamber. I don't know which one it is right now, but it is sponsored by about 15 to 20 Democratic legislators from throughout the nation. And so we'll see where this all ends up. But the bill right now has $845 million in funding for Section 202 and Section 8 project-based rental assistance programs to help cover their COVID-19 costs, including staffing and disinfecting and stuff like that. There's $300 million to support and expand the service coordinator program, $50 million for the installation and service fees for wireless internet in HUD communities, $7 million for a one-year extension of the integrated wellness and supportive housing demonstration. And then Leading Age Nationals also asking members to take action if they're interested. I included the link there to Leading Age Nationals campaign letter writing action tool that they have. And you can sign a letter right there that will then be sent to your legislative representatives. So that link is there if you'd like it. Lastly, before we move on to questions, just a brief update on PPP. The deadline was extended to August 8th from June 30th. This is largely because there are still funds in the pool. And so any members who have not yet applied for a PPP loan but wish to do so have until the 8th to apply. As I said, there's some money left. There's about 134 billion left that people can have access to. And Leading Age National has released a tool/resource for members to use when filling out the application, so they can fill it out accurately in case you feel uncomfortable with the whole application process, and the link is right there for you if you'd like. All right.
All right, before we get into any questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos on the screen. These are the organizations that continue to support the association, but your organizations as well. Without their continued support, the Educational Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. So now for questions, I only have one right now, but it is, will the nursing home task force be expanded to include all of residential care, or will it stay nursing home specific?
I believe it's going to remain nursing home specific, but I don't know how you talk about the state's COVID-19 response in nursing homes without touching on all of long-term care. There's a variety of business models in the state, and oftentimes these health systems all interact with one another. And so while the task force may be titled Nursing Home Facility Task Force, I don't think that all the other issues will be ignored because of it. I believe it was largely set up because of the criticism the governor and the state has received regarding nursing homes in particular, especially around regional hubs in the Senate Oversight Committee. But I don't know how you can be looking to solve the COVID-19 problem in the state without addressing all of long-term care.
All right, thank you for that. I'm not seeing any other questions, so it looks like we can go ahead and move forward here.
Okay, great. Thank you, Dalton. We will now move to our situation update with a focus, of course, on Michigan's current COVID status. So this first graphic is a representation of the overall caseload and deaths from COVID-19 for the past 3 weeks as of yesterday. You can see that the U.S. numbers continue to increase in terms of daily cases. And on Monday, about 45,000 new cases were identified across the state. The good news is that the death rates do continue to level out and in most places decline. This next graphic identifies the states with increasing daily cases, and you'll know that the map is remarkably more deep orange as time goes on. You can see that Michigan has increased its daily caseload by between 50 to 100% since 2 weeks ago. And most states have seen this dramatic increase in new cases as well. Here we have a graph, and these graphs are all from based on Johns Hopkins data. This graphic identifies the states with increasing, the rapid rise of cases in Michigan, the increasing cases in Michigan. And you can see that there was a rapid rise all along and then a sharp decline. And you'll see in the past couple days, again, an increase in the 7-day average number of new cases. And that's been rather dramatic upswing there. In terms of total cases over time, the impact is not quite as significant, but you can see a small, very small, but continued incline as time passes. This last slide from the Johns Hopkins series shows the Michigan cases per 100,000 persons. And again, you can see a small but slowly increasing number of cases. So in this case, in this slide, the cases are ordered by the total number of cases cumulatively by state. So Michigan at one point was number 3 across all the states in terms of total cumulative cases. We've now moved down to number 12. We were experiencing a definite decline only 3 weeks ago, but we can see that starting about 2 weeks ago, a really sharp increase. Very few of these states with high cumulative numbers continue to plateau or are decreasing their caseload at this point. Next, we have here our standard caseload slide. These again are the 7-day average, rolling average of new cases in Michigan as of yesterday. It's important to remember though that because this is only 60 days, that the left portion of the slide is always moving forward as well. So if you look at it, you always, if you're comparing the left slide to the right part of the slide, there were higher increasing numbers earlier that have now dropped off because of the passage of time. So the right side kind of looks more larger and more dramatic than it might have before. So it's important to remember that this is time-sensitive data. However, that doesn't mean that we're not surging again, and we have seen sharp increases again over the past 2 weeks. And again, the only good news here is that the death rate continues to plateau and remains at very low rates. So we included in this last data slide the My Safe Start map that was posted as of yesterday, but it only shows data through 6/26. Even so, you can see that the 4-county area that includes Lansing has moved to high transmission ratings. Grand Rapids continues to be at a medium-high risk. The regions are categorized by the percent of positive cases by testing in each area. Overall, across the state, only 2.9% of cases tested come back positive. However, of course, there's a wide variation rather, across these regions. And that includes a rate of over 20% for Lansing, meaning that 20% of all of the tests come back positive in Lansing, and between 10 and 20% for the Grand Rapids area. So now we're going to move on to our general updates. As the pandemic has progressed, we have found that several areas of continued concern moving forward. So we're going to touch a little bit on each of these general areas that are of concern to our members, with a focus on staffing resources, because the department's put out some new resources for that, as well as a discussion about ongoing visitation and testing issues as well. Before we go there, though, I would like to remind everyone that a lot of the messages from the state come from 2 sources. MyHand, which is the Michigan Health Alert Network. And that's the primary way, actually, that the state issues some of its guidance, such as the testing guidance was put out that way. The link to register to receive these alerts has been included here and will be included in the Q&A again. Members might note that it takes several days to start to get messages through this system. The other avenue is the Michigan State Police, because we're in a pandemic that requires emergency responses. A lot of the messages will come through the state police. And the link to register for their messages is also included here. We have discussed with the state that providers are not used to receiving a large number of their directives in this way, and the state is considering sending direct emails to the administrators for in all the licensed settings using the LoRa database, but they will probably continue to use these communication mechanisms as well, since they are often communicating with unlicensed settings in addition to our long-term care licensed facilities. So we're going to talk about staffing this morning. One of the major concerns that providers have had with testing is the fear that a large number of staff will be asymptomatic but then will test positive, which could very well force a staffing crisis for a given provider. And that's happened in a few facilities. To address that, MDHHS has implemented what they're calling rapid response staffing, but at this point it's only available in certain areas of the state, and those counties are listed here. There are some specific criteria to be able to access this short-term resource. An agency called 22nd Century Technologies will provide up to 1 RN and 4 aides per shift for up to 72 consecutive hours if needed. Facilities will have to determine themselves how they meet the criteria before requesting assistance. And they have to complete a survey attesting to that need within 24 hours of the request. If for some reason it's found later that they didn't meet the requirements or they didn't submit the attestation survey on time, they will be responsible for the staffing costs that are incurred. The criteria is pretty consistent across each provider type that can access the program, but there are some small and somewhat subtle changes between them. For nursing homes, the facility must demonstrate that at least 50% of the scheduled staff missed at least 2 shifts in a row. The facility must attest that if they're part of any corporate system, that they have first requested support from other entities in that system, and that they have called on corporate to help as well. So sister facilities in a corporate system requesting help from corporate level staff. They must have reached out to local medical volunteers through their local healthcare coalition. They have to have called in their own management staff to assist. They have to have done all these things before determining that they're eligible to receive this short-term staffing assistance. They also have to have tried to access other staffing agency assistance and been turned down for whatever reason. For homes for the aged, the criteria for need is the same. At least 50% of scheduled staff must have missed 2 shifts in a row. The facility would need to respond also in a similar way. However, this set of criteria differs a little bit from the nursing home set in that if the facility is part of a CCRC, they also have to look toward help from other entities within that system. For all provider types, again, there must have been a request to a staffing agency for assistance first. For unlicensed assisted living, again, the same basic need criteria. At least 50% of scheduled staff must miss 2 shifts. I'm sorry, you moved too far, I think. Blake, there. 50% or more of the scheduled staff must have missed 2 shifts in a row. The protocols are pretty much the same. You must call for management to assist, and you must have asked for assistance from any sister corporate CCRC agencies if you're affiliated in that respect. For adult foster care, though, the need criteria are a bit different. The large or congregate AFC must have experienced a loss of at least 50% of the scheduled staff, but only for 1 shift. Support from other affiliated organizations and management must have been attempted first. For small AFCs, again, they must have experienced a loss of at least 50% of scheduled staff for that 1 shift, or there must be some clear indication that staff will not be able to report for the next shift. Since the number of staff used in these smaller settings are also much smaller, the rules are a bit more flexible for them. So MDHHS has issued a frequently asked question document for this specific rapid response program. And again, it only includes certain counties in Southeast and West Michigan that we identified earlier. Any licensed residential setting can apply for assistance. Each provider type must meet the need thresholds, must have enacted all the steps in the emergency protocol to respond to the crisis, and must have reached out to other staffing agencies first. Once a provider decides that they've met all the criteria, they themselves must contact 22nd Century Technologies at the number that's listed here on the slide, and request only the number of staff needed to a maximum of 5 per shift. And that would be a total of 1 RN and a possibility of up to 4 aides. The state will support these staffing needs for up to 72 hours only. If a facility needs services beyond that time, it will be at the facility expense. Remember that if using this service, though, you have to submit an attestation that you meet the criteria, and that's done through an electronic survey process within 24 hours, or the entire cost will fall to the facility. If facilities continue to have staffing needs beyond that time, or if perhaps they don't meet the criteria at all, 22nd Century Technologies can still be contacted for support at the provider's own expense. There is also a portal through an entity called Metaphys that can also be used to connect providers with a network of staffing agencies to be used as needed. And the contact information for joining that network is listed here. If a facility can gain staffing support through another agency, they're not eligible for the program. And you have got to go through local agencies before you can request state help. The state, though, has identified that if there are difficulties in submitting the attestation survey on time, an email should be sent to this state address, which is listed here. And the state would waive the 24-hour rule if they're having trouble doing that, and if they notify MDHHS within that 24-hour period that they can't get into the system or something. The needs for services should be discussed with 22nd Century, but obviously the services are meant to be focused on help with ADLs, assistance with infection control and prevention, and possibly environmental cleaning needs. All their staff will be checked and screened for background checks, licensure checks, and for TB testing. And each facility can request a documentation to that effect. What is not going to be routinely provided is COVID testing. These staff do not have to specifically undergo COVID testing to work in your facility, but if a facility is doing whole staff testing while they're in the building, the state expects that these support staff would be tested as well. And any additional questions, the state has developed an email address for them, and that's posted here. Okay, so since this is new material, I thought we'd take a short break here for a minute or so and take questions if there are any.
All right. Again, before that, Leading Age Michigan, we would like to thank our business partners, and we are always thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo. So we would like you to just kind of take a look at the names on the screen here. Just like we did with the sponsors, without their continued support, just like the sponsors, all these exhibitors, the education foundation would be unable to be as dynamic and innovative as we are. So therefore, when you are considering a purchase of goods or services, please remember the page with all these logos and all these names, and consider making a purchase from one of these fine organizations, as they help not only us, but your organizations as well. So I do have a couple questions. I tried to register for the MI HAN and was declined to receive alerts. If you are not a nursing home, can you still participate?
My understanding is, yes, I was able to sign up, and I am not a nursing home. I do believe that I do have a contact number at the department, and in fact, I had to get some help from the department to negotiate registering as well. So if, in a response to this, I'll make sure that you have the contact information for that. In the interim, it really is important to be registered on My HAN, because it took me a while to figure out myself why I hadn't gotten some of the notices from the state, and it's because they were only putting them out through My HAN and or posting them on a website without telling anyone.
All right. How quickly will they be able to deploy us staff? If we cannot utilize this service until we have a severe need, it seems a little late at that time to get staff sent to the facility.
The criteria does seem a little strong. I do understand that. I don't know in practice how this will play out, to be honest with you. I don't know how helpful it will be. It is meant to be assistance only in severe critical cases. The department in general expects everyone to work through their staffing issues just, themselves, but they're mostly concerned in response to having a high number of COVID positive staff that might be an immediate change. So if you had testing and all of a sudden 10 of your staff were found to have COVID, that would be an immediate thing. It wouldn't be something where your staff is dwindling down. That's the kind of scenario that they have in their mind here. So it'll be interesting to see how it plays out. I don't know how helpful this will be. I don't know how prevalent COVID is among our staff right now. We'll have to look and see.
All right. How does MDHHS reconcile the rapid response staffing requirement to use staff from sister facilities with the desire to not cross-contaminate facilities and by not using dedicated staffing? Is this an exception because of the staffing crisis that precludes the provision of necessary care? Any suggestions as how to limit COVID-19 transmissions if using the RR staffing?
I think that that's a really important consideration. I think, though, that no matter what you do, if you don't have enough COVID dedicated staff, you're going to have to find staff to serve these residents as a last resort. If you're moving staff, obviously you do not want to move staff from one kind of entity to another. But I don't know that there's a problem in moving staff from one part of a non-COVID area to another non-COVID area per se. Obviously, you don't want to transfer these people a whole lot, but before you use the state resources at the state expense, yes, the state's going to expect you to look at all of the avenues. And again, this is meant to be a short-term thing if indeed you have an immediate, very quick decline in staff. I think that this is a good question to ask the state what their expectations are. I think that they would prefer, of course, that you utilize all those safety precautions, but this would be a dire situation where you would obviously have to find someone to serve residents if you didn't have enough dedicated COVID staff.
Okay. Someone said that the risk map has been updated. All of Michigan at least listed medium risk. Everyone should be weekly testing now. This is just an FYI. A lot of us in low risk, we're not checking the map regularly.
Wow, I'll have to look at that. I pulled that map off the website yesterday, so but that was old data, so perhaps they've updated it today, and we'll take a look at that. Thank you.
All right, it looks like that was the last question that I have, so we can move forward.
Okay. Okay, so we're going to review testing requirements. I think everybody must be tired of hearing about it, but unfortunately there's still issues with it, and we get a lot of questions about it. This first slide talks about an update to the CDC testing guidance for nursing homes that was updated as of July 2nd. Again, as with many of their updates, there are actually very few changes, but I'm always afraid we're going to miss something if we don't look at these very closely. So they've rewritten this guidance so that they now discuss the guidance for testing residents separately from the guidance for testing staff. Each nursing home is expected to have a testing plan. That's a CDC recommendation, and of course that's required in Michigan right now. The CDC also notes that while these are recommendations for nursing homes, they are also recommendations for all residential senior settings. So you can use these guidance to define your own practice in non-nursing homes as well. Testing is considered a critical part of the reopening process, and the CDC notes that it's really understanding what the current spread in a facility is and directly following up action that works to prevent further illness and death. In other words, testing is just the first step in a rapid response to an outbreak, which can be as small as one new facility acquired case. And those immediate actions to isolate, track potential other exposures, and review infection control procedures are the things that have been demonstrated to save lives. So this ability to act on testing information quickly was highlighted in a recent CDC report. It was a Morbidity and Mortality Weekly report about the actual Detroit experience. In this report, they decided that symptom-based screening without testing was inadequate to detect COVID transmission, since, as we all know, much of the transmission seems to be coming from asymptomatic staff. Through the use of a CDC team and the Detroit Local Health Department, the City of Detroit initiated what they called point prevalence surveys. And that just means whole facility testing of residents and staff at a given time, all at the same time. During the first round of this initiative in March, they found that 44% of all nursing home staff and residents tested positive. And of those, 37% ended up being hospitalized and 24% ultimately died. 12 facilities that had high counts continued to participate in the program, and they received on-site infection control and prevention support from the health department and the CDC. And the percentage of newly identified cases went down from 35% for that group to 18%. A review of the outcomes from this initiative indicated that ongoing transmission was continuing, mostly because of incomplete resident and healthcare personnel cohorting. In other words, they weren't isolating well enough or fast enough. Some residents who were moving from ongoing outpatient care in and out of the facilities, such as hemodialysis, were also bringing the virus in from the outside. They also noted that some of the facilities did not have enough private rooms to quarantine persons who were suspected of COVID, and thus transmission continued, even though people were in observation for possible COVID. The big message from this study is very much in alignment with the CDC guidance about the need for testing and the need for that testing in particular to inform immediate and next actions, such as applying transmission-based precautions quickly, quickly excluding staff from work, isolating completely, and monitoring the facility ability to maintain infection control protocols, as well as, obviously, close monitoring of confirmed cases. The CDC now recommends repeat testing of residents and staff whenever there are facility-acquired cases. Note that just because you admit someone doesn't mean that you have something to really worry about in your facility. But if you have facility-acquired cases, they suggest testing every 3 to 7 days until 14 days have passed with no positives. And that, of course, is in alignment with one of the Michigan testing provisions. Currently, there's another CDC initiative that includes Detroit, and that we found this kind of interesting. They are testing donated blood samples anonymously. They started to do this in 6 cities last March, and they're now adding 19 other cities, including Detroit. And so what they're going to do is they're testing about 1,000 blood donation samples each month for 12 months in the city, and then they'll do it again at 18 months. And they're only looking for antibodies here to see how prevalent COVID infections actually have been compared to the testing data that each state might have. And of course, they do warn that respiratory infections are not transmitted by blood, so that there should be no worry about this blood initiative at all. So we're going to end the discussion on testing with a quick review of the Michigan nursing home testing guidance. The department did send out an update last Wednesday that changed the email address where providers should submit their testing reimbursement forms. We did review the reimbursement form, and it seems to only address the test kit and the collection fees part. We're going to talk about that in a minute. Obviously, providers will have to keep detailed information about testing costs and findings. And the entire testing strategy for Michigan is on their COVID website if you need to review the entire thing, and that's at the address listed here, which again will be in the Q&A. So we went through the entire guidance and could not find how providers were going to be reimbursed for actual laboratory testing. The guidance does directly state that reimbursement will include the full lab cost for the test if it's not reimbursed by a third party. So we've reached out to MDHHS to ask how that mechanism is supposed to work, since the reimbursement form doesn't include that. And we've also asked them to define the period for covering unreimbursed lab costs, whether it's only effective as of June 15th or whether previous costs might be covered. And they've not yet responded to our questions. And most of the questions we have received have been about the requirements, the scenarios that require testing. So we're going to briefly review that today again. We were alerted that there was a article in Crane's Detroit that implied that if a nursing home had negative testing for 2 weeks, that they didn't have to test anymore. And so one of the reasons why we're going through this today again is because that's not true. Each facility must have completed an initial or baseline test. They must test all new or returning residents, and they must quarantine them for 14 days or until they're testing negative to test. And of course, they must test each resident or staff who might have symptoms. But weekly testing must be completed for residents and staff whenever there are active facility-acquired cases in the building. Remember, only facility-acquired. So if you admit someone who is a completely new resident, who's never been in your facility before, you do not have to do weekly testing of residents and staff. What you do have to do, though, is weekly testing in areas of medium or higher risk. For any facility in regions 1 through 5 and 7, you have to test them at least once. The original date was before 7/3. That's been extended to 7/17. They do ask that you do the testing as soon as possible, although they've given you a couple more weeks to get that done. So we'd like to throw out a question here to the group, and you can respond via the chat mechanism. For those who have completed testing in the past week or so, are the test reports coming back on a timely basis? We know that we heard horror stories of weeks before some people got their tests back. And the department assured us that that was not going to be the case. So we're wondering if indeed you're getting your tests back. And are there any members having trouble getting PPE at this point, considering the amount of PPE that's going to take to do these tests? So if you can respond to those questions via the test box, we will review them at the end of this section. So visitation, this is another thing that we're going to do a brief review of. We've also gotten a lot of questions about this in the past week. For nursing homes, assisted living, homes for the aged, adult foster care, independent living, and hospice residential facilities, there are 2 types of visitation currently allowed. Visitation for those who are at end of life or seriously ill with a change in condition, or those who need ADL assistance from families in order to improve their condition. You can move forward. Okay, thanks, Mike. So the department has placed a lot of conditions on this. Visits must be scheduled, but they're not supposed to be a routine. They must be done by appointment, and facilities must keep an accurate log of these. There is a limit to the number of visitors at a time to 2, and only for a limited time in the building. Obviously, all visitors must mask and must use safety precautions. Facilities must be looking at the traffic flow through the building and use designated entrances only. Screening, of course, is required for anybody coming in and out of the building. Each facility is required to have access for testing, and we've got a lot of questions about this. We understand this to mean that they need to be able to arrange for testing if needed, not that testing needs to be available right then and there on site. We do suggest that, especially for non-nursing home facilities, that if arrangements have not been made in advance for the laboratory, that you might identify where free testing is available in your community, but we don't think that you have to be able to test immediately and have a lab on site immediately to do testing if something should happen. Signage must be posted that identifies COVID symptoms and the precautions that must be taken. This is another, the next piece is another area where there's been a lot of questions. There must be adequate staff to assist with transporting residents to and from, and to monitor visitation, as well as disinfect any visitation areas between visits. We don't believe that that means that you have to have someone standing and observing 100% of the time, but checking perhaps, reminding them about safety precautions as needed, etc. Visitors must be educated to report any symptoms that might occur within 14 days of their visits. They do encourage that visits be outdoor when feasible. Obviously, movement in the building must be limited, and obviously not through any COVID positive areas. The facility must provide PPE and educate on its use. Social distancing is required. This other piece, the staff person on campus, is kind of related to, do you need to have someone in attendance during observing the visit 100% of the time? Our understanding of this requirement is that there must be staff on campus available and trained in infection control. that person is not the person who needs to be, nobody needs to be in 100% attendance to your visitation, but you need to have some monitoring and you need to have access to resources during visitation. Discouragement of any food sharing, and of course, there'd be no visitation for positive COVID or residents who might have symptoms and are in an observation. So that's a review of the visitation guidance, and we know that that guidance continues to have a lot of restrictions that are perhaps negatively impacting our seniors. So one of the positive things that we heard this week is Alterum has a program called Program to Improve Elder Care, and they are looking at specifically the impact of COVID-19 on nursing home residents in terms of the effects of social isolation, limited activities, food issues, and their overall fears about COVID. So they have as their stated goal to lift the voices of the residents during this pandemic. The survey takes about 20 minutes. It's for residents to do. It will be released next week, and it will be active until August 31st. Residents can do it using a computer, tablet, smartphone, or whatever, and it can be anyone's equipment. Doesn't matter. It doesn't have to be theirs. So we will forward this to nursing homes when it's issued, because we believe that data from this might be a really good mechanism to let the department know and better understand the negative impact of isolation on our residents. This next slide is a reminder of a training tomorrow through the CMS QIO program. It's about managing staffing challenges. The QIO training program provides weekly webinars, and members can access old programs as well. We have listed the previous topics here, and these links will be on our Q&A. You can access old programs. So we've included some nursing home due date reminders here. The annual resident survey information for the QMI initiative has been extended out to 9/18 because of COVID. CMP fund applications for telecommunications due August 1st. Testing plans should already be completed, but remember, you don't have to submit them. They just need to be available. Baseline, initial, or what we're calling interim testing for regions 1 through 5 and 7 must be done and completed by 7/17. Nursing home license renewals are due 7/31. And there is National Guard availability for testing until July 27th. But after that, the state plans to find a private vendor to assist. And I believe that the National Guard availability is also possible for non-nursing home entities. So if you believe that you need to do some testing in your home, if you might have a COVID presence and you need some help, we suggest you contact the state or your local health coalition to start. So as Dalton was talking about earlier, the governor has formed a nursing home COVID-19 preparedness task force to address the issues that are most likely to continue if we have a second wave. The goal for the group is to coordinate stakeholder input across all the departments and specifically to look at the data and the gaps in the data and using data to determine the threat of COVID in our nursing homes. Right now, we know the data accuracy is still suspect. Eventually, the group will make recommendations about what data is needed, what the best practices are. The commission list is posted here, and note that David Herbal is on the commission. Last but not least, we wanted to be sure that nursing homes are aware that with the change in remedies that were issued in QSO 20-31, any F880 infection control tag now must be addressed through a directed plan of correction. If it was received after June 1st. So what that means is that if a facility with an infection control tag after that time, cited during a survey that exited after that time, if they've already submitted and gotten approval for a plan of correction, they're going to have to do it all over again using the CMS directed plan of care correction form. We're kind of looking to see how this plays out. We have asked the Bureau for a copy of that form, but they have not been able to give us one yet. They're still looking for it. So this could be big for a couple of our members if you've had an infection control tag since 6/1. So that's all the content we have today. We'll now pause for some final questions. Blake?
All right. Let me pull them up really quick. These were just kind of the responses regarding the lab testing.
Right.
Somebody said, received our results in less than 2 weeks. Someone said, test responses are delayed. We were promised 24 to 48 hours, and it took several days for some of the results. The first.
I'm glad you're letting, excuse me, Blake. It's really important that if you are struggling with that, please let us know. We will get back to the department. There's still a testing work group that meets, and we are part of that. So we want to make sure that we're giving them some feedback about how things are going. I'm sorry, Blake, go ahead.
Oh, you're fine. The first week our lab took 6 to 7 days, but the second week we got them back in 24 to 48 hours, some stragglers at 72 hours using a private lab.
Okay.
And then this week was slower due to the holiday, but no other problems. And then I have one more question. Testing for assisted living still has not been required and will not be reimbursed, correct? Is our ability to assist, or is our ability to allow visits for assisted living residents tied to testing requirement, or simply that testing would be available if any symptoms develop?
I don't have a good answer for that. I think that obviously testing is not required in anything but nursing homes right now. I do believe, though, that if you ask the National Guard to help, that is covered by the state. So I do believe that there is some access to state resources for testing. I don't know that it would be at the same frequency. I mean, I'm not sure they would cover weekly testing over time like they would for a nursing home if indeed it was warranted. But I do believe that you can ask for National Guard testing. How that ties into how the region might reopen to visitation, we're not 100% sure, but I really think that the driving piece is that is to have a sense of what the community transmission rate is first. I think that the governor and the epidemiologists won't be looking at anything until those community transmission rates come down. And they're specifically fearful of nursing homes. Now, that doesn't mean that there isn't COVID in those other settings. I'm not sure that the department has a good sense of how it plays out in those other settings, but we have not heard anything from them about mandating testing or opening up visitation based on testing for any other settings other than nursing homes.
All right. Still no written state guidance on outdoor visits?
Unfortunately, that is correct. We're hoping for something, but we have not yet gotten any directives in that respect.
All right. Baseline test results for one facility were lost with no guidance about how to remedy or how to move forward despite repeated attempts. Our other facilities are receiving results timely.
Okay.
All right. It looks like that was the last question that I had. So if you do have any further questions or you have anything that you think of, we have everybody's emails right up here, so you can send them to Safe and Calm. Or if you have an advocacy question, go ahead and send that to Dalton. Deanna should be able to answer all your questions as well. We would like to say thank you to both Dalton and Deanna today for all their information. We would also like to thank, I believe we had around 65 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything that you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Just a quick reminder that we do have another this exact webinar, Safe and Calm COVID-19 webinar, this Friday at 11 a.m. Eastern Standard Time, and you should receive an email notification from that. Deanna or Dalton, do you have anything else that you would like to say?
No, just stay cool out there. I hear it's hot everywhere.
I'm all good.
All right, sounds good. Everyone have a great day, and we will see you Friday.
Thank you, everyone.
Thank
Bye.
you.